Okay. So David, can you put yours on mute? Thanks. Thank you. Okay, thank you guys. We'll kick off. I'll open with a karakia. I honori hi korea ki te atua. He mangawa wanga ki te whanua. He whakakaro pai ki nanga tangata katoa. Hanga e te atua he nakahuai. Ki roto, ki tana o matao. Whakatanga gia tō wairua tapu. Hea wahine, hea tohu tohu, ia matoa. Hea akau hiko I ngā mahi mō tēnā re. Amene. Honor and glory to God, peace on earth, goodwill to all people. Lord, develop a new heart inside all of us, instill in us your sacred spirit. Help us, guide us in all things we need to learn today. Amen. Okay, thank you guys for joining us for our first quarterly forum. Or rather, we did have one in January on the 23rd. Since that forum, we've had one monthly disability working group. We meet bi-monthly, and in the off month, we are sort of working behind the scenes, following on from different projects, different meetings, etc. Bear with me for a second. I was going to have all this ready. Okay, in our last meeting, we had presentation from a Southern Building Society community banker who was really interested in just finding out what hassles the disability sector are having with regards to accessing money, finance, locations. So it was really good to make some very good contacts there. We had Moko Matau from the National Disability Strategy team join us, and it was very good listening to them talking. Because of that, we've sort of amended and tied in a lot of our action plan, which I'll talk about shortly, in line with what the National Strategy is doing. Lots of things have been duplicated or triplicated around the country. And it's good to see that everything's starting to come together. Lots of gaps in how to actually progress towards have been identified. One of the very good things that has been implemented at the moment is the South Island Patients Information Network, something we've been working on behind the scenes with Jack and a lot of the other teams, so that the patient's file will have a little flag identifying their requirements. It's a work in progress. I think some of the disability working group were approached to provide some details. Like for myself, I explained that I was a paraplegic T5 and what that means. At the meeting, we've finished with a round table, which is what's happening in the various areas. One thing we're still looking for is someone in the mental health area, hopefully from the Central Otago. So I've made a couple of contacts here, just waiting to hear back. One of our working group members, Philippa, spoke about the IHC research report, From Data to Dignity, and it was really interesting that people with an intellectual disability have worse health than any other group. So that's sort of a bit of concern. Hopefully that'll be taken on board on a national level. One of the biggest issues for people up in North Otago is trying to get to Dunedin Hospital, and St John is looking at a feasibility study to see if they can provide some form of transport. I have completed a accessibility audit on the Southern Community Services building. I'm just in the process of typing up the report. as would be expected, there's not a lot of compliant items with regards to light switches, etc., not being color contrast and things like that. The accessible toilets can be improved in that, but I'll be hopefully completing that audit by the end of this week. So that was sort of the key points of our last meeting. Any questions, guys? Okay, I will move on then to the disability strategy ongoing action plans. So the goals of the disability strategy, just as a little reminder for everyone, it was formed in 2021. The goals are be bold and purposeful, be inclusive of individuals, whānau and community, be equitable, responsive and accessible. So the ongoing actions, and as I said, that we've sort of now in line with the National Disability Strategy. All projects set up to develop, design, review new processes, policies, or to oversee these must have consumer representation on the project group, including at least one member of the disabled community. And the idea is this person will provide guidance to staff on the role of the consumer advisors and making sure that staff are aware of their requirements and obligations when engaging with disability consumers. Develop of training modules for consumer advisors with more regular engagement. This is something that's happening on a national level. Action 2 is engagement with and accommodations for the disabled community will be assessed through the Health Quality and Safety Commissioner's Consumer Engagement Quality and Safety Marker. My apologies, that's long worded titles. And here, continue annual question about what services are doing to increase equitable access to services for the disabled community and work with services around particular areas of need, and to utilise responses to commence targeted projects with individual services. The third action is to review the Te Whare Southern's website, including recruitment systems, and make recommendations on improvements needed to achieve Accessibility Charter accreditation. The Charter is something that all national government-owned entities have to have their web complying with the Accessibility Charter. So what we're hoping to do is to review the Accessible Charter requirements, identify any gaps, and then develop recommendations for implementation to ensure that the website achieves the Accessibility Charter accreditation. I'm not aware of one website yet across the country that has achieved that. So that's hopefully will be the first. Action point 4 is that we will continue to develop the Te Whare Southern's digital systems, recording and use of relative data, including alerts about consumers' needs and any documents they have in place. So that information is flagged, as I said, on the consumer's file. And it's ongoing investigation of the potential for codifying the impairments. Support Jack and his team in efforts to improve the information. Provide education to key staff on the effective and efficient utilisation of the impairment field. Ensure outpatient clinic lists identify patients with disabilities and required accommodations. And ensure inpatients identifying as having a disability have accommodations required clearly articulated on MyCare plan boards. And investigate including disability into the work of Poe Manukau. And biannual auditing of inpatients with completed impairment field. So you can see there's a lot of stuff still to go with getting this data correct. And the last, few more action plans. Number 5, extensively increase update of staff's disability awareness training with opportunities for all staff members. So we're looking at having a 1-hour tailored interactive training delivered to various health care teams, so that's specifically targeted for them. Develop 1-day disability module in conjunction and incorporate the hidden disabilities training modules. Target training to new intakes of students and graduates, and the training to form part of the triennial SMO expectations and annual refresher training for all staff. Gather data on effectiveness of in-person training 1 month afterwards. So this is to ensure that the training being offered is being effective. Come up with innovative solutions to get people involved where time restraints affect availability. And this is one of the biggest hassles, is trying to get people away from their jobs to take part in training. And when feedback is, identify specific staff that we can actually target their training and build this into the response and improvement plan. Identify activities for Disability Awareness Week, which is early December, and get Hamish to talk about and video resources on Pulse, and build a suite of online training available whereby people can actually access the training when able to. We're looking at increasing number of disabled staff and support provided. We're looking at this by launching the disability survey on all staff to identify perceived barriers to staff feeling supported, and to identify what else we can do as an organisation to provide support. One of the biggest things we've noticed is a reluctancy sometimes of the disabled person to put their hand up and actually say, I have a disability. This is sometimes because of their own unconscious bias, the way they have always perceived and seen how disabled are treated. And it's trying to break down these barriers. And one thing is we're trying to ensure that hiring managers are provided with training on recruiting fairly and equitable. I know recently I heard a comment that no one with a disability would work in a certain section of a facility, and yet there were people overseas in high risk areas with disabilities working in areas that in New Zealand they said that no one would. So it's just making sure that the hiring managers are aware of these things. The Disability Working Group is continuing to contact groups working in the health and disability sector to ensure that their members can obtain the relevant information. And we're going to continue to promote and hold these quarterly forums. And we're looking to obtain feedback from the attendees at each event to identify what else the community wants to hear from us. The Disability Working Group is to identify through the sector engagement any gaps in the provision of necessary information. And the Disability Working Group members to identify within their own networks what the issues are in their communities and to bring these to meetings. And members to identify through their own engagement what else is needed with regards to information provision. To assist in that, what we're working on is providing all of the Disability Working Group members with like a little checklist so that we can tick off and ensure that are we meeting these. The clinicians to engage with patients, family and whānau early during the patient's stay in hospital, so that they are involved in all aspects of the patient's care from admission to discharge and after, including being provided with information in the appropriate format for the period post-discharge. So that's ensuring that it's connected with other work streams, prioritise training to frontline teams to increase confidence in proactively engaging with the parents, patients, family and whānau. and to develop links with Service Directory to streamline referral processes to community organisations. The working group has been looking at an up-to-date directory of community groups, and this is a work in progress. We had a draft one which we went through and identified. Thank you, Catherine, for all the work you did going through it, and identified a few gaps which has now been worked through. And this directory will be available on the hospital's website. Carrying out accessibility audits. As I've mentioned, I've done the Southland community building. I'm looking at getting into Gore. I've identified certain areas in Wockery Hospital, also the existing hospital. Patient stories, we're still looking at recording and hearing patient stories within the southern area, which we can use for training and passing on to various networks. And that is it. So thank you. It's a bit long-winded, guys, but I thought I'd sort of read and let you know there's a lot happening in the background. And we'll have a sort of amended just the headlines of that, put on the keynotes of this meeting, which will go on the website. Excuse me.
We've got about 5 minutes for questions on that, if anyone's got questions on our action plan.
Thank you, Catherine, for all the work you've done there, combining our one with the national one. It's good to see that it's all in line. I was at a meeting the other day, and I mentioned about the health passport and how a lot of what we're doing is hopefully going to supersede it. And a few people at the meeting didn't even know what the health passport was, which was a little bit disappointing. So the next meeting, I'm going to have copies to hand out for everyone. Any questions, guys? Next time, I'll make sure that the interpreter gets a copy of all this so you know what we're talking about. So my apologies.
And perhaps if we've got a couple of minutes with no questions, maybe one thing I might just duck in and add, John, is that in relation to, and I've forgotten the number now, but one of the actions that we are working on is about our IT systems. So as John said, we rolled out at the end of November a new patient information system. So that has the capacity. So one of the things that the working group had advocated for was that we would have a impairment banner in that system that would act as an alert or a flag. It would always be present on that patient profile, so that anyone who was looking at their patient profile could see immediately that that person had identified an impairment and information that we needed to know about that. Now, because we migrated from a previous system that didn't have that capability, we are starting largely from scratch with that. So if you have engaged with us since the end of November, then it is likely that we would have added something into that section, but I know that there's a lot of people that we don't have information for, and we should have information for. And what we want to do as well is check how effective having that information is there, whether it's being seen, if we're doing what we need to do with that information, but that's only as good as the information that we have in there. So my plea here is that I want to hear from as many of you as possible, please, with any information about yourself that you would like us to place in that impairment banner. Some examples, just to give you an idea of the type of information that can be helpful, we're really talking about a one-line sort of statement, because you don't want it to get too bogged down and flow onto the next sort of screen, etc. But one line that says DEF needs a an NZSL interpreter for every appointment. That's a simple one. Or low vision, please ensure that all letters are sent large print, and that the patient is oriented to their room, etc., when they arrive in hospital. I'm not telling you what to put, obviously, and what is needed will vary depending on every single person, but that's the type of information that we want. We want to know what the impairment is, but also what we need to do to accommodate you when you're coming into contact with any of our services. I will put the email address into the chat in a moment, but I would really encourage you to do this for yourselves if that's something that you would like us to have on record about you, and encourage others that you know to provide us with that information as well. Even if you think we should have it, we may do, but we also may not now that we're in this new system. So it would be great to ensure that we have as much as possible.
And the good thing is, once we've got all this in place, as I sort of mentioned, it's ensuring that the staff are trained to ensure that they understand the flags. I see, Jackie, you've got your hand up, and then Tanya.
Yeah, Catherine, with regards to adding information to patients, can parents do it for children? And what about power of attorney? Can they do it for someone who's got power of attorney? Where's the, I suppose, the privacy or conflict or whatever in regards to that?
Parents can do it for children, yes, and if you have power of attorney for someone, then yes, you can do it for them as well.
Right, thank you.
Tanya.
Sorry, slow on the technical skills there. I guess it's sort of not dissimilar to Jackie. So previously, IDEA services, particularly where people are living in residential supported situations, had provided a lot of information under there was a project called All About Me. And so there was a lot of information provided around people, particularly, obviously, from my perspective, people with intellectual disabilities. So I know I might be stating the obvious, Catherine, but from what you're saying, that information is no longer in your system and that needs to be redone? Or
it's not necessarily no longer in our system. I don't know whether it's in the same place that it was in the last system. So we just, if you think that we have that information, you're very correct. We may well have that information. I'm just trying to do a double check so that if we don't have it, we can add it.
Okay, so would it be feasible to send perhaps a couple of examples to check that it is there rather than the entire list or people
great.
kind of thing? Yeah, a spot check if you like.
Yeah, that sounds great.
Okay, thank you.
Thanks, Tanya.
Hey, Tanya. Okay, if there's no more questions, what we'll do is we'll invite Emily to join us. Thank you, Emily. Good to see you.
Kia ora koutou. Thank you for having me. Yes, apologies for being a moment late. I hadn't realised I had to register in advance.
No
So
problem.
I've really come along today just to update you a bit on what's going on with the new hospital project. Happy to chat about other questions. I may not have all the answers, but I have a fabulous team here and I can certainly go away and get those for you. Do you want me just to launch into that, John?
Yeah, that'd be good. Does everyone, maybe a little 30 seconds on your position and for anyone who doesn't know you, Emily, if that'd be good, thanks.
Yeah, sure. Ko Emily Tukawengawa. I'm the project coordinator with the new Dunedin Hospital project team. I've been with the team for about 6 years, so I've seen a lot of the process. I wasn't quite here from the very start, but I've seen an awful lot of the process to get us to where we are today. I don't have a clinical background, but I've been really lucky to be able to be sort of involved with organising a lot of aspects of the project and seeing how things work. So I'm certainly not coming from any kind of expert point of view, but one of the particular areas that I've been involved with and been passionate about is community engagement for the project, and so that is something that I can talk to you about today. I've got a little wee presentation to put up on the screen, but there's nothing particularly that you need to read. It's really just something for me to sort of talk to remind me what we're here for. Can you see that?
Yeah, thank you. If there is anything that we've got a couple of people with a vision impairment, Emily. So if there is anything you might want to verbally describe for us, thank you.
Sure, great. Thanks for that, John. So where we are at in the project is that you may well be aware that the outpatient building is going up now. I just saw them putting the roof on today. So that one is well underway, and the plans are for the outpatient building to open in 2026. So that's only a couple of years ago. The inpatient building is in the sort of final stages of design, but they have started piling for that. So construction is sort of underway there as well. There's a picture up there on the screen showing the two finished buildings, gives you a bit of an idea of the comparative size of the outpatients and the inpatients building. If you have seen the outpatients building going up and thought, oh, that looks quite big, you're probably interested to sort of compare it to the inpatients building and see that it really is considerably larger. So that's where we're heading. We're hoping that the inpatient building is going to open in 2029. So the program for the outpatient building, just to run this through quickly, is the piling and foundations have been completed. The actual structure of the building should be completed by the end of the year. The facade will actually start going on pretty soon. If you have driven past and seen the white plastic wrap around it, that protects the building while they're painting it and putting the facade up. So it'll be a very exciting moment when that plastic comes down and we see what the building looks like. And there's a wee sort of rendering there of it on the screen showing you what it should look like when that plastic wrapping comes off, and it's quite a beautiful looking building. Got some fins on the west side there, and part of the reason for that is to prevent the building getting too hot in our glorious Dunedin sunshine. Believe it or not, that is an engineering requirement. So once the building's actually sort of completed, we would move into commissioning and moving into the building, and that's really where our team is focusing a lot of our attention now. We're starting to think about actually moving in, what we at Southern need to do to make that happen safely, what we need to line up in terms of communication with the public, with our patients, with our community, with our staff, training, information. What do we need to make sure that on opening day, things go smoothly and safely for everybody? Now, I think you would have heard us talk before at this forum about the way that we have done our consultation with our users, community and staff users, in the design phase. And that was quite a long phase over several years where we had a lot of user groups or FIC groups. And those groups were made up of staff. A lot of them did have community advisors, community representatives on them. Some of them had some other sort of subject matter experts. We had about 50 of those over time, so there were a huge number of those groups. Overarching all of that, we had a group called the Clinical Leadership Group, get my names right, which was a group of clinicians, and later on there were a couple of community advisors on that group as well. That was quite a large group of senior clinicians and community advisors, and they were able to provide oversight of that design, of the engagement with users, and provide expert advice where it was needed. Now that we've moved into this new phase of thinking about the transition, that larger group has been disbanded, and we now have a smaller group called the Clinical Transformation Group. We've got the same chair, Sheila Barnett. Our deputy chair is Professor Patrick Manning. We've got a representative from each of the key clinical groups on our staff, nursing, medical, allied health, and we've got 2 community advisors on that group as well. Now, one of the really exciting things that we've been able to do in the last few months is actually establish a community advisory group, and they would be advising the PMO, so that's the team I work with, and the Clinical Transformation Group, and they've been set up really to become an expert community advisory group, and they're called the Community Voice. I know that some of you in this group will know about it because you are members of the Community Voice as well, but just to sort of let you know, what we were trying to achieve with that group was, firstly, as I said, we wanted to set this group up to be quite a long-standing group who would have a lot of information about the outpatient building and about the planning, and therefore we would be able to go to them to get advice and to get feedback in quite a responsive way. One of the things that we know about a project as big and complicated as this is it takes people quite a while to get up to speed with what's going on. So in order to have really authentic, useful engagement with the community, we actually need to have a group that has the time and space to learn about the project and what we're planning. The other really key thing that we wanted to achieve with the group was a broad range of representation across our community. So diversity in lots of planes, you might say. And we've worked hard to do that. We feel pretty happy. We feel that we've got a pretty broadly representative group. Of course, we can't represent every condition or every lived experience. We recognise that, but we feel that the group we've got together are very interesting, experienced people who are able to represent not just their own lived experience, but the needs of the wider community. So on that group, we have got representatives who have lived experience of physical disability, sensory disability, neurodiversity, long-term conditions. We've got whānau with children with long-term conditions. We've got people who live in rural and regional areas, members of the rainbow community, and we have a good range of age and ethnicity on the group. Now that group has only met a couple of times so far, so they're just sort of starting off on their work, but we do see some really key opportunities for this group to feed into the planning and the success of the outpatients opening. So the first thing that the group is doing is they're developing what we've called a patient experience strategy. And really that's about defining what we would like the patient experience in the new hospital to be. That's a kind of overarching document piece of work that we could then use as we're doing our planning, both within our group and with the services, to sort of check in on what is the expectation of the community about what the patient experience would be. Are we meeting that expectation? If we're not, what can we do about that? Can we change what we're doing to meet that? Can we make plans to meet that in the future? Can we mitigate anything in the present? And that's a really important piece of work. And as I say, that's the first piece of work that the group's got going on. But there will be lots of other opportunities for the group to get involved and make fantastic contributions. They'll be able to feed back on details of the transition and operational planning. The digital program are very keen to get them involved and get some feedback and advice on the planning for the digital program. We're hoping the group will be able to develop some patient journeys. Again, that's a really useful tool for us to test our planning and test what we're offering to the public and the community to see if it's meeting the expectations of the community. They may have the opportunity to feedback on specific service planning, on travel planning, on the way that we communicate with our patient and our community, make sure that we're pitching that right, that we're telling people what they need to know, and essentially ensuring that the community, the patient and the whānau are centred in our planning and in the experience that we're able to offer when we do get to opening day in a couple of years' time. So that's my main piece of news to update you on. As I said, happy to answer questions about that or other aspects of the project. And if I'm not able to answer those today, I can take those away and come back to you.
Thank you, Emily. Any questions, guys? I see Sarah, you've got your hand up. Sorry, you're on mute.
Try again. Good afternoon, Emily. It's lovely to see you, and thank you for sharing that update. It's been really quite interesting sort of watching the journey of what's been taking place over the last few years. I've got a particular interest in the consumer group that you just mentioned, particularly around the consumer advisory group and involved in planning and development of how things are going to look and progress. That's a particular area of interest of mine. Oh, excuse me, a tech issue. I've got something coming in I want to get rid of. That's better. I just wondered, in the community voice group, do you have people from the mental health and specifically the eating disorders and body awareness sector? that's something that we are really widely identifying as the larger part of the health sector.
I am not aware of that in the group. In terms of people's declared interests, we do, as I'm sure you know, at Southern, we do have some mental health patient advisors who we can go to specifically for that. But as far as I'm aware, we don't have eating disorders represented in that community group at the moment. As I said, we know that we can't represent every condition and lived experience. So I think the idea would be going forward that if we were to lose a member, that we would ideally be looking to probably recruit someone from a different area of representation. And so that's certainly something that we could bear in mind for the future as being something that's important to the community.
Thank you for that. And yeah, we're always interested to hear about any potential opportunities for inclusion in those areas.
Well, of course, we do know that this particular forum here is our sort of expert group that we can go to hear about what the disability community in Southern wants, and we will continue to do that. I should make it clear that the community voice is not replacing all of our other consumer engagement, and so if we had issues that we felt were of particular concern to the disability community, we would very much want to come to this group and hear what you had to say about it.
Thank you, Sarah. Jackie.
Sorry, me again. Sarah, in regards to your question about the eating disorders, I am one of those people who are on the community group, I think we're called. I have a daughter with an eating disorder, so that is one thing that I will definitely be watching very carefully and communicating to the group on. So hopefully that might help in any way, and of course we could catch up at some stage. And
That sounds
yeah.
wonderful.
Yeah,
Always
because I
happy
think you
to
might be an
catch
honorary
up.
as well. Are you, Sarah?
Yes, that's right. So always very happy to catch up.
Yeah.
We're involved in high-level system advocacy work is one of my main roles. And so I take part in the various sector initiatives that have been happening over the last few years, including some feedback on the new Dunedin Hospital design and submissions for that. So yeah, we'd be very keen to be closely connected and involved. So
Yep,
be good to
great.
catch up with you, Jackie.
Yep, done. I'll catch up with you that way.
Tanya.
Hi, Emily. Awesome to see the progress that's actually happening as you truck around Dunedin. So it's pretty exciting to see that. Probably just similar to I'm sure lots of interest groups, but I guess just making sure that there's some really robust conversations and feedback from the intellectually disabled community and family and whānau, because we have had some engagement over recent years with, in particular with the hospital, and unfortunately that's generally been where things have not gone particularly well, and we've had some really good positive conversations, and it'd be really good to keep that front of mind, particularly from a planning perspective, and the long-term strategy would be good. So just, yeah, putting that in there as well.
Thanks very much for that, Tanya. Absolutely. Again, recognise that that's an area that we don't have somebody with lived experience of intellectual disability on the group. We are very happy to continue to come and give regular updates to this forum, and if there were particular issues around intellectual disability, we could come to this group and ask if there were people who specifically wanted to comment on it as well. So I can certainly make a note of that.
Thank you, Emma. The good thing is with the Disability Working Group, we've got representatives from just about every disability sector, which is good, except specifically the mental health. Roger, you've got your hand up there.
David. Myra is
Oh,
there.
David,
Oh,
can you put
oh.
on mute, please, because Philip and Roger are speaking.
Sorry, interpreter couldn't see before. There's a deaf person signing. Awesome, interpreter can see me now. Okay, so talking about the Dunedin helicopter. And there's the new building happening there and the different sections. Is there going to be, I'm just thinking about the number of helicopters and the different sections that are going to be allocated for the helicopters. What are we thinking there?
So there is a helipad on the inpatient building, not the outpatient building, which is the one which is going up now. There is a helipad for one helicopter to land at a time, and there is space for a second one to land. That is not currently fully budgeted for. The space and the engineering is there so that in the future a second helipad can be made functional. But the functioning helipad will be on the inpatient building.
Thank you, Roger. I think, David, did you have a question? And then we'll go for Sarah.
I read that people with a lot of disability are not really around the table, not very much to give you some ideas, and that is where she'll be lacking time bit around this area. Yeah, we
Okay.
need to be more involved.
So, David, we have got Philippa from People First on the Disability Working
Of
Group.
course, yeah.
Thank
All
you.
right. Oh, yeah.
Yeah,
Okay,
well, as I
sorry.
said, David, we're certainly happy to come to this group as well. We're not trying to replace the value
Yeah.
of this group at all. It was about, as I said, getting a group that could be very responsive to the project needs, but we certainly want to continue to engage with this group.
Thanks, Emily. Thanks, David. Sarah, and then I think Jackie.
Sorry, I can't find the button to raise my hand, so I'm doing it the good
Yes.
old-fashioned way.
Works well.
Yes, quick question regarding just mentioned that the inpatient building is still undergoing its final stages of design. Will there still be opportunity to make any submissions at all to any changes to that design, or is it set in concrete? Reason being is we actually presented a petition in 2021 with 14,000 signatures for the inclusion of a improved inpatient facility for pediatric eating disorders, as there are none in New Zealand other than at Starship, which South Island children are excluded from. It's for Auckland residents only. So our petition was for the inclusion of a significant change to have an inpatient unit for pediatrics. That's rather been put to one side, and we're aware there is one room. That's the first part of the question, really. Will there be any opportunity to revisit this? This is something that we're currently discussing. Also, the inclusion of lived experience at all in any of that design, which we haven't to date had any access to. So yeah, those two parts really would be quite important to receive your feedback on.
Yeah, thank you, Sarah. I'll start with the second question in terms of lived experience engagement. I mean, you mentioned, and I do remember your contact with the project back in 2021 around the paediatric facilities, and so in that sense, I guess where people have approached us, we have engaged with them. Now you've probably got a much better, clearer memory than me of exactly what happened, but I know that it was discussed at the time. In terms of changes to the design, it is very largely locked down. When I say it's in the final stages of design, I mean that they're talking about, the details of where to sort of put services, finishes on walls, that kind of thing. We are certainly not able to make any changes. There is a process whereby a request for a change could be submitted. That has to be escalated through the governance of the project to the Ministry of Health, because a change at this stage in the project would be a very expensive thing to do. So it's not something that we in Southern have the ability to do or to authorise. There is a process for requesting a change, but as I say, it's not something that we can do. And in order to initiate a change like that, there would have to be, I think, a pretty clear case that there was a sort of a clinical need for that change that hadn't been able to be considered earlier in the process. And again, you'll probably have a clearer memory of the details of the discussions in 2021. But since that was considered at that point, I think that probably that would be the sort of view that it was considered, for whatever reason a decision was made, and at this point you wouldn't revisit a decision at that point. But of course, yeah, you are welcome to contact the project or Southern with feedback or views if you want to. I have to be honest though and say that we are not expecting any large-scale changes on design to be authorised at this point.
Okay, thank you.
Sorry, I cut myself off. Yeah, thank you very much for that additional information. Yes, I do remember very well that meeting. We gave feedback following that meeting to the ministry in an additional supplementary submission, which identified a great deal of missing data. And we have followed through with that, and we're in discussion around this again. Because of that missing data. So we believe that there wasn't appropriate consultation in the design process or inclusion of that data. So yeah, it was an interesting meeting, and it's certainly something that we are following up with because of the reasons that we've outlined. So yeah, thank you very much for outlining the process that we should be following, and it sounds like that we're on the right track to do so. Understandably, it would be an expensive process, but unfortunately, it's even more expensive to families to lose a child to a fatal eating disorder presentation. And we have a large number of really severe and fatal cases starting to emerge because of lack of appropriate early intervention and treatment. So this is a critical area, and I would really like to reiterate that this is something that you are aware of, that we are revisiting this because of the high data and fatalities that are starting to emerge.
Thanks, Sarah. Yes, it's good to hear that you are talking directly to the ministry about that. I'll certainly advise the team that that conversation is ongoing between you and the ministry, and should we be advised that we should look at that again, then we can do so. As I said, noting that at this point in the project, any changes are very difficult to secure, but as I say, good to hear that you're continuing to have the conversation with the ministry.
Thank you, Emily. And we would also welcome any discussion at all about what improvements could be made within the current design that is there. We'd be very keen to offer any parental and carer and specialist lived experience feedback in what is there that we could potentially improve upon. So that's something that's really important, that you know, if we've unfortunately missed a generational opportunity to make significant changes for our family, we can at least try and see what we can do with the current design that's in there to make improvements to the programs that are going to be run within it.
Thanks, Sarah. I will certainly pass that on to the team when they get to the service planning for paediatrics.
Thank you, Sarah. Jackie.
Once again, just in regards to the lady who from Idea Services and intellectual disability, I have two boys with autism, and both have intellectual disabilities. So I have an adult who's 23 and a young son who's 10. So neurodiversity and intellectual disability is something that I'm very strong on, I think you could say. And I'm also involved with CCS as well. So hopefully through that work I can help contribute to the consumer group.
Thanks,
Thank you.
Jackie. You do bring a big range of experiences to the group, so very valued member.
No, I agree with you there, Emily. Jackie's sort of very valued member of our working group. Okay, any more questions for Emily? Looks like everyone's happy at the moment, Emily.
Hey, well, thank you so much for having me. Very happy to come back and talk and update you again whenever you would like me to. So please,
definitely.
let's keep in touch.
Very good. Thanks very much.
Thank you. Kia ora.
Thanks, Emily.
Over to you, Catherine.
Kia ora. Now, I apologise, I still have my camera turned off. I've had really patchy internet today. Just while I'm getting my slideshow ready though, Nadine wanted to say something as well.
Yeah, I was just hoping to put a plug in for the Your Way Kia Roha Leadership Group holding an expo at Age Concern Hall in the Octagon on May 9th. That's 11 to 1:30. So organisations can have a table space available to members of the public and clients of Your Way Kia Roha to show what services you do have, and gives them the opportunity to see quite a few different organisations in one go. You can just contact Your Way directly for table space if you'd like it. And if you want to come along and catch up and find out what other services are available for you or your family, then just rock on, and there's no cost. And some other hat, which is the Your Way Leadership group, along with David, who'll be at the door greeting people as they arrive, I believe. His gorgeous smile. So we should be great.
I would be away.
Oh, you're not going to be there, David. Never mind.
I'll be in the North Island.
That's a shame.
This year.
Yeah, because we've done it. David's been part of all the work going on to get this off the ground. So hopefully we'll see you there.
Excellent. Thank you, Nadine. Good plug.
Thank you.
You guys are doing good work. Okay, over to you, Catherine.
Thank you.
I see it's 1 o'clock, so if everyone's happy for us just to carry on for another 10 minutes.
Can someone just tell me if that's come up
Yep, no, it's come up.
for you? It has, great. Okay, I will try and race through it quickly because I know we're now officially over time. But for those of you who have been to our sessions before, we try to cover some of the highlights of the feedback that we've received over the last month. Now, one of the reasons that we do this is this relates to the consumer engagement quality safety marker that John referred to in our actions, which is an assessment we do twice a year on our consumer engagement. And part of what we're trying to do under that is make sure that we're reporting back to our communities on the feedback that we've received and what we're actually doing about it. So I've got 4 examples to share with you today. The first one was a complaint from a blind support person who was staying in the hospital with their spouse. He was an inpatient. They had travelled from out of town. It wasn't expected that they were going to be staying in the hospital, but the support person was obviously not able to drive themselves back to their hometown. In the past, they had had border privileges, including meals, etc., while their spouse was staying with us. But this proved really difficult this time around. They were unable to get home due to the distance, and there were usually other supports that they had in place that were just unavailable due to the unexpected nature of this admission. What we found out was that actually usually the patient management system that I talked about before would have had that information really clearly in that profile, but we didn't have visibility over that because we just updated it at the time. Because of that, we have updated that now, and there was a meeting between the patient, the spouse, and one of our managers who identified that it was actually unlikely to be a repeated circumstance. We have apologised because we didn't handle it in the best way possible, and we are taking that feedback on for others in those situations as well. We had another complaint from the whānau member of a consumer who had a brain injury. So the concern was that there was insufficient communication being provided to the whānau member, and that because of the brain injury, they weren't able to feed themselves, and there wasn't enough awareness that that was an effect of their condition. We are still engaging with that whānau, and we are engaging collaboratively with Health and Disability Advocacy Service in relation to that one as well. Another patient with a brain injury was discharged from one of our units without support in place. So a parent had travelled from out of town, been told that they were not going to be discharged, so returned back to their home. And then the next day when discharge was approved, the parent wasn't advised. So this so then the patient drove to Central Otago independently. So we acknowledged in this case that there had been a breakdown in the communication between multidisciplinary team members. So we had quite a few people involved in the care of this patient. That ward is now auditing all their discharge planning with a particular focus on liaising with whānau in the case of all of the discharges. And the final example that I have for you is for a patient with a learning disability who was unable to communicate his needs to people who he wasn't familiar with. So this patient lives in a home with others, community residents, and is able to communicate with people that he lives with and his carers, but in a hospital just wasn't able to explain what he needed in terms of his foods. So he needed to have very soft food and using a teaspoon, for example, but we didn't have that recorded the way we needed to have it recorded. So once they advised us, the care organisation advised us that we weren't getting this right. We did start using the My Care Plan board to some degree, but it wasn't completed fully, and we didn't quite get it right every time. Now, as a result of this complaint, this particular ward is rolling out a Disability Awareness Month in May. So we had another complaint in this ward some time ago. So this ward is very aware that they need to increase their awareness of all staff about how to accommodate disabled patients and their whānau. So we have a few activities planned for that awareness month. We are going to be doing some group sessions with staff. We're doing some profiles of consumers with disabilities just to highlight how what some examples are of how we can communicate more effectively with people that do have barriers to communication. And we have a couple of other things that we're looking at as well for that. But the ward leadership especially is very committed to making this work and to making some improvements in the practice and what they do across that ward. So it's quite exciting, and I'm hoping to be able to provide some positive feedback on that. And hopefully, if this particular model works, rolling that out across other wards as well. So that's happening in May. So we're launching that this Friday.
Thank you,
And
Catherine.
that's all I have, but I'm happy to take questions as well. Oh, have we lost our interpreter while I was sharing?
We have, yeah.
Oh,
Philippa and Roger, you're okay?
you're on mute, Philippa.
My apologies, guys, for going over time, but I think it was very important listening what Emily had to say. Any questions? Okay.
Only one. I'll be away on the 9th So most probably I won't be at the expo in the front door doing another job.
No problem. Thank you,
If
David.
anything changed, I will tell you.
Excellent. No, thank you for that. Thank you, guys. If there's no more questions, what we'll do is I'll finish off with a karakia. If you do have any questions or whatever, please drop us a line. Catherine put a little email address, disability@southerndhb.govt.nz in the chat there. But yeah, or send me one, johnmarable@gmail.com, and we'll sort it out for you. So my apologies again for going over time. Okay, karakia. Kia tau kia a tautau katoa, te atawai o tau te tau awaki e tū karati, me te aroha o te atua, me te whiwhi kata hitanga ki te wairua tapu aki akaki. Amene. May the grace of the Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with you all forever and ever. Amen. Thank you very much. Thank you, Catherine, for organising this.
Thank you,
And
everyone,
we'll
for
be in
coming.
touch.
Thanks, Catherine. Thanks, John, and everyone here.
Thank you, guys. We'll be in
Great.
touch, Sarah. Thank
Thanks,
you.
everyone. Thank you.
Bye. You okay there, Catherine?
Yep.
I just thought we'll hang on board for a couple of seconds.
Right. I'm here. Sorry.
Okay. I see
Oh.
Philippa and Roger still there. Yeah.
Can you hear me?
Yeah, can you hear
Oh.
me okay?
Yeah. My internet has been really patchy. That's why I turned my camera off. It's just been really patchy.
Yeah. It's just
So
been one of those
apologies,
things.
but yeah, it was good though.